Good morning and welcome to our webcast. I am your moderator Mehta. This is session number 88 and hopefully you will find this session as educational as ever. We have a complex bifurcation LAD lesion with the additional multiple discrete lesions which will also need to be treated. Let me take you to the cardiac catheterization laboratory so that we can demonstrate the case live, and in the meantime the case is also being, you can watch it on YouTube live. Samin, good morning.
All right, good morning from Mount Sinai Cath Lab, and sorry for a little delay. What happened is we are moving, we are changing our floor.
Yes,
so
I
all
heard
little confusion.
You're moving up in life from 6th to the 7th floor.
Hopefully not too high.
And it took you only 25 years to do that.
That is true. They made a very good place now with the state of the art, because what happened is there is a lot of need for ICU beds and telemetry and CCU. So this area where we used to be will be converted into a telemetry and CCU now. So there will be a new and clearly that is what going on. At present we all know, whether it's in India or America, it's a more is the acute care, because rest of the care is delivered as an outpatient basis.
Exactly right.
Okay. So with that note, without further ado, we just go with this quickly the case. We can go through the slides because we'll brief in our part and then we'll do so that we can finish just few minutes of the time. This is the our case number 88,
that
65
exactly
year,
right.
Yep, 65-year-old patient has class 2 angina and positive stress echo and had a 3 vessel disease. And Dr. Kini will show, let's show the angiogram.
So this is RCA, the main RCA itself is disease free, but you have moderate disease of diffuse disease of the PDA, significant disease of moderate size RPL. And then we are to the left side, left main is okay, his OM1 has significant disease and this is the LPL. Branching LPL, maybe the lower branch has disease, but more important is the LAD. You have proximal LAD, mid LAD and distal LAD, all spot lesion, and 2 diagonal, actually second diagonal is the one moderate size diffuse disease all the way up to the distal.
Straight away not the best surgical targets for the LAD to diffuse the disease.
Well, actually you are right, but with the age having a 65,
right,
probably many people will do, they will connect the lima to the mid LAD after the diagonal and then distal. So lima attachment at 2 places,
right,
the jump. Many people I have seen cases they have done lima attached to 3 segments of the LAD. In the past they used to do endarterectomy, which we know doesn't have a good long term good result, so that's not done. So
how much of his ischemia, Samin, improved after the because the RCA is massive?
Yeah, the RCA is massive. So this is basically if we go back to our slide. So after this, patient being diabetic with a 3 vessel with a syntax score of 25, patient was sent to surgery. So clearly the heart team discussion, and then with all the options given to the patient opted for complex multi-vessel PCI. And of course, he started on a very aggressive medical therapy, and this is a very important point. The class 1 is that you need to have a discussion, and during the discussion I would say the interventionalist should not be part of it. It should be the cardiologist or the referring physician as well as the cardiac surgeon. So this patient then was decided, so because of the extensive lesion and with a 25 syntax score, that go for the PCI of the LAD diagonal bifurcation, multiple lesions in the LAD, and of course it makes a full from the appropriate criteria. So with that note, let's start and tell us what will be the strategy. What do you want to do here?
I think we will take care of the distal LAD lesion which we see now. We can put a short stent just at the distal LAD, and maybe 1 stent can cover the prox mid LAD lesion. And
distally also there are 2 lesions, no? One is around the apex. And
yeah, I think the apex you have to leave it alone. It's very distal. You actually see in this view.
Yeah.
Further down.
Very further down. Yeah.
Further
right.
down. Yeah.
Okay.
That we are not going to go. I think we'll just take care of the.
And precisely for that region, that is not a great case for the cabbage. But here surgeons had no issues actually. They said we'll do the surgery. But I would be definitely, I'm a surgeon, again, since we are not the surgeon, I would be a little concerned about it, but
And I know you plan to leave the first diagonal.
Yeah, first diagonal we leave it alone.
Okay.
The second one we pre-dilate and probably a 2 to 5 stent there with the mini crush technique.
And that's also diffusely disease diagonal also.
Yeah. So that will be the issue, that we save one diagonal.
Now there was another reason also for this patient we have waited a couple of months. When he first presented to us, he was only on single medication. I think he was not even on aspirin. He had seen the cardiologist and was just started on medical therapy, one single medication, and then he, refusal for to understand his disease process and refusal to take medication. So taking everything into account, we felt that we have to start him on medical therapy first, make sure he is compliant, whether he is going to accept PCI or bypass surgery. So it took a couple of visits to the general cardiologist, as well as I have seen him in my office twice before he could understand that optimum, full medical therapy is very important no matter which treatment strategy arm we are going to.
With the possibility of a dedicated two-stent strategy, you have a 7 French guide, or is it?
Yes.
7 French, okay.
You are on 25.
Yeah. So not much calcification, in fact almost none.
Yes. So in this case, but definitely none. And ready? Yeah, I think you're right. The apical LAD is very tempting also, but I think we can leave it unless there is just some trouble into it.
Not even dilate it with the balloon. Well, if you put a balloon, then you are committed to a stent.
Yeah. Okay. So while as Dr. Kini mentioned, the plan would be that wire LAD diagonals and do the distal LAD PTCA. By the time when they do and put a stent in the distal LAD, apical LAD for the time being no, and then we'll come back to when working on the we'll be working on the proximal and mid LAD
before
diagonal.
you go into that, a very important question, mainly because we have such a large international audience. A patient like this being done in many developing countries, surgery is actually economically less expensive, no?
Yes,
Absolutely.
agree. And
Absolutely.
that is what I think not there even here. That's the first treatment option we gave to the patient.
Right.
And nothing wrong in telling the patient that when interventionally should not be part, only surgeon and a cardiologist, and you need to tell them that is the only treatment option available for them.
Got it.
And of course they have to be on good medical therapy, which includes aspirin, statin.
That to me is one of the best teaching points what you mentioned, because really that is what makes the guidelines and the appropriateness criteria truly valid, that first optimize the medical management.
And that exactly happened. Cath was done on August 2nd, and our patient coming almost 6 weeks later with a very good hemoglobin A1C of 6.4, a good LDL of 60, so a good medical therapy. So clearly, and he is on various those Invokana and new anti-diabetic medications.
Right. Yep. Samin, all yours. Tell us what you are discussing about.
So we do quickly on the 2 points, and again we always try to do a latest of the latest. That is one is the recent trials of coronary bifurcation lesions, and secondly the long-term prognosis after non-ischemic FFR, because the data are emerging that it's a different value in a stable coronary artery disease versus acute coronary syndrome. So first is the trials of the coronary bifurcation. We know that there are various techniques: single stent, conventional stent strategy, where one stent with a bailout of the side branch, which occurs in anywhere from average 15 to 20% of cases, is the preferred approach. But some cases you need to use a two-stent, and particularly those are with a shallow angle diffuse disease and very tight lesion of the ostium, that you may need to put a two-stent, and various techniques of the crush, decay crush, culotte and tap techniques have been suggested. So basically what we have few trials. One is the EBC2 study, basically provisional T stenting in the large bifurcation from England, UK, and basically showed that these cases of the 200 patients were randomized to provisional stent versus culotte, and basically showed that almost no difference, although little favor on the provisional stent approach. Clearly that lower primary endpoint and MI and basically the MACE rate, and so no difference in stent thrombosis.
Samin,
Clearly.
all of
Yeah.
these were done with the newer stents?
Yeah, all of them were done with the newer stent with a combination of the Zions and Resolute.
Excellent.
So, all these data are the latest studies. So, clearly showed that the two-stent strategy nowadays is okay. It's no penalty. Remember in the past, the two-stent strategy had a higher thrombosis rate, higher event rate. Is not the case at present by the good technique what we do at. So, the second is the culotte stenting versus the TAP. So, another called BBK2 trial from Germany basically say that an angiographic study of the 9 months basically show that which technique is better, culotte versus TAP. And basically remember the TAP basically is that you bring the put a stent in the main vessel and you bring a stent from the side branch into the main vessel to a kissing balloon dilatation, and basically showed that the culotte had a lower residual stenosis of 6% versus 17% overall, but more importantly that has a trend towards lower TLR. As you can see here, culotte in the green and red being the TAP stenting, there is no difference in other endpoints of the MI death, but key is that overall target lesion failure for the main vessel as well as for the side branch was lower in the culotte stenting. So, that culotte was preferred based on the BBK2 trial. So, then question is that what predicts, you put a 2 stents, what are the chances that we will have an event, and what can we predict with the 2 stent strategy, that what are the factors for major adverse cardiac event. These are the data from the Korea, from the COBIS-2, the Excellent and Resolute. This is a combination of all kinds of stent, the Cypher, Resolute and Giants and Promus, and all basically showed that there are various factors, but overall as you can see now that in 2 stent strategy at follow up at 3 years, that your event rate was about 17%, but more importantly the stent thrombosis is less than 2%. So, usually 1 year stent thrombosis now with a good technique is about 1% at 1 year. So, very important, and TLR is about 10 to 11%. So seems to be that 2 stent strategy is a reasonable approach, and but what are the predictors, and this is actually individual endpoints. The more important is that we have predictors for target vessel failure with a 2 stent strategy at 36 months. One, if you are left main have a higher target vessel failure, high syntax score and diabetes, those were the 3 adverse factors. So, we know that. So, if we even in the current generation stents you have that you have the higher the target vessel failure will be in the left main, high syntax score and diabetes. Now, second generation stent clearly showed that significant reduction, 74% reduction in the TVF by using second generation stent, always use a non-compliant balloon and final kissing balloon dilatation, which decrease the event by 50%. So, very important with a 2 stent strategy by using a new stent, non-compliant balloon kissing balloon dilatation really helps to decrease the overall the event with these cases at follow up. So, now there is very nice by Leward and team has a very nice editorial, actually the review article in JACC intervention last month, which is the contemporary approach to bifurcation lesion and treatment, and I think this really puts things together, and basically is that we have bifurcation lesions, majority of them we start with the provisional stenting, and what you do is after provisional stenting the proximal segment, the very important what learned now is that your stent size should be the identical 1:1 to the distal vessel after the bifurcation. So, not the proximal. So, you have a 2.5 mid LAD and 3/0 proximal LAD, you put a 2.5 stent. Then your proximal is pot. So, you then proximally you dilate with a short balloon to a proximal size which could be your 3/0 and so. And key is after that you of course decide based on the side branch. If your side branch is good, so side branch stenosis is less than 75% and there is a the residual no dissection, normal flow, no ischemia and so forth. So, if that is the case, so you leave it alone. So, if patient has no dissection, it's a good lumen, leave it alone. And now of course, if there is a side branch compromise, then of course, in those cases that you need to do a pot stenting, you go through the branch, open the kissing balloon dilatation and then you do a pot or second or repot we say. Now, in some cases dissection, then you put a second stent whether tap technique or the reverse reverse crush. So, now if there is a more than 75% residual stenosis and clearly that you already have a dissection and so forth. So, those cases you plan the two-stent strategy. So, key is that if you have a less than 75%, you can leave it alone and you can do FFR and may just dilate the proximal area. But if you have a significant obstruction of the side branch with the dissection and ischemia EKG changes, you better do a two-stent technique. In my opinion, the TAP technique is very good, but learning on the data that maybe the culotte is okay also. So, that two-stent strategy done correctly is okay in about 25 to 30% of cases, and that is what we learned now, which is on the right side of the screen, that complex 1 to 111 lesion with difficult side branch, high risk of occlusion, which is the narrow angle, and of course, the large side branch, you should go with a dedicated stent strategy. So, I would say very simple. I do not think the controversy should be that one stent or two stents. No, we as a physician interventionalist have to identify which region is going to use two-stent strategy. That happens in about 25-30% of cases, and you go with a two-stent strategy on those cases and get the best outcome. So, this is one point. The second is the long-term prognosis after non-ischemic FFR. This is the data from FAME trial. Now, we actually have the 5-year data where patient with a multi-vessel disease were underwent PCI angiographic guided versus FFR guided. In FFR guided, 32% of cases did not have PCI or lesions did not have PCI because FFR was more than 0.8. So, we learned that strategy did very good in terms of the lower MI, death, TLR, stent use, dye use, radiation at 1 year. So, what happened at 5 years? So, whole question was that you have a tight lesion, angiographically you would have put a stent, but you did FFR which was more than 0.8 and you left it. So, what happened to these cases? And this is a very important observation that these all patients were with a stable ischemic heart disease, patients were a stable angina, they were not acute coronary syndrome. And so, basically what we found that if you take a myocardial infarction at 1 year was 8.7 versus 5.7, 3% difference in favor of FFR. Now, guess what? Now, you go to 5-year outcome that almost actually it is the difference really becomes less. It is like a 2.4%, but more importantly the slightly higher MI rate from 5.7 to 9.6 compared to in the angiographic guided group from 8.7 to 12. More importantly, if you take a TLR which was 9.5 and 6.5 at 1 year 3% difference, now you go to actually 5 years, you start seeing the catch up phenomena. So, clearly that while your double incidence of TLR at 5 years based on the angiography, but on the FFR guidance almost 3 times, and that led to the overall outcome not different. So, basically what does that mean? So, it seems to be that deferring PCI on a long run based on FFR even in stable angina group may have some catch up phenomena, and this actually we know that if at 1 year based on the FAME 2 trial that there was no difference. Medical therapy alone with the FFR of more than 0.8, leaving it alone at 1 year there was no catch up, but you can see there was some. So, like overall 1% became like 4% after 6 to 8 months, but we do not have the data of more than 1 year, although we have FAME 2 trial 2-year data, but that did not talk about those patients who are FFR of more than 0.8 and were left alone. So, what happened is there is a recent paper in JACC last week about the data from the VA center about long term prognosis of the deferred acute coronary syndrome lesion based on the non-ischemic FFR, and they went through the various numbers 0.75 or 0.8 and basically showed these are the various group patients that some of them only 4% was 0.8, but 1/3, 1/3, 1/3, 8.1 to 8.5, 8.6 to 9 and more than 9. So, in the blue bar is the ACS and the stable patients was in the red. So, clearly that as a common practice they did FFR and whether it is acute coronary syndrome and or a stable ischemic disease, they left based on the recommendation that leave the lesion more than 0.8, do not do the PCI. So, what happened? So, clearly what we understand, patient with ischemic heart disease, stable versus acute coronary syndrome had a higher event rate, acute coronary syndrome 23% at the 6+ years of follow up compared to stable syndrome. So, all the double the event which we know ACS will have it. They also took the patient propensity match to match the patients in the entire cohort, and the data seems to be still similar. Then what basically they learned that also the majority of this was mediated by higher TLR and higher myocardial infarction in the ACS patient. So, they are very important observation. So, now if you dissect down to the group, basically the 0.81 to 85, 85 to 9 and more than 9 in the entire cohort or in the propensity match, the stable syndrome versus ACS, which is in the blue, is a very good observation comes that the higher FFR of more than 0.81 has an event rate more in the ACS patient, while in the stable CAD it is flat. So, what does that mean? It seems to be that maybe 0.81 is not appropriate for the ACS patient, maybe it should be higher. And to answer that question, they went with a various cutoff value and basically found that 0.85 for ACS and 81 for stable ischemic disease, which we have been told. So, seems to be first time methodical observation of this differential FFR impact of the deferred PCI based on the FFR, giving us the data that answer is not clear or uniformity, that whatever we are taught in the stable ischemic disease may not be for the acute coronary syndrome. So, why it is? So, basically there are some reasons for it, and one of them to me the most important is microvascular injury, particularly in the acute coronary syndrome time, because that will do, it will prevent vasodilatation and it will give a false negative FFR. That is the most important. Now, that actually leads to, we know that if you put them on antiplatelet therapy for 3 to 5 days, their FFR may change. So, clearly the FFR which was 0.85, which were deferring, but truly probably the 0.78, because if you give antiplatelet therapy, and that is why the European Society of Cardiology says in ACS patient you should wait for 5 days before doing FFR, but we know that nobody waits 5 days, we do it as when patients present, and majority of them done within 2 days and so. And the other important point is the plaque instability and vulnerability with a ruptured plaque and thrombus formation will compromise the flow without change in the FFR. And therefore, what the author suggested also that many of these cases with FFR of 0.84, 85 and so, maybe you should do a imaging, and you see in those cases when there is a ruptured fibrous cap and so, and thrombus or ulcerated plaque, maybe those are the patients should get stent even with the FFR of 0.85. Again, this is a work in progress, but really we need to understand this point in the future with some more prospective data. But clearly the first time methodically the topic has come up. 2 months ago we showed it, that post procedure FFR also predictive of the event at follow up, and now the second one is that FFR at the baseline has a differing prognosis in ACS versus stable ischemic heart disease patients.
3 or 20 high pressure.
Okay. Now, Anu, we can come back to angiogram. Dr. Anu, tell us what you did now.
That's distal, I think was just an undilatable lesion.
Wow.
Maybe we needed a cutting balloon.
Okay. So, now
So
what,
we did.
what stent you put?
There's a
Tell
ProMus.
everybody,
We did a ProMus 2516. Then we went high pressure post up to 22 atmospheres. But the thing is, one side
looks a little undilated
yeah,
there.
yeah, very. But see, it's just one surface. Other one expanded well.
Right.
So I think you go higher pressure, then we are risking perforation there.
Okay.
So we left it for now.
Fine.
We pre-dilated the side branch. We pre-dilating the LAD now, and then we are ready for the bifurcation stent.
Okay.
There's a 2 to 5 high pressure balloon up to 14. That's what we see.
But you take a picture now.
Yeah, we can pre-dilate the LAD. His creatinine was a borderline high. It went up to like 1.8 last time after cath.
Okay.
So it
You're
is
watching the.
That's fine. So, the what balloon we have now?
This is a 3020 high pressure for the LAD. We pre-dilated with the 2.5 that we used for the distal, and then I think we should decide. I think we can go with the 2.5 or 2.5 for the diagonal.
Diagonal 2 to 5.
Okay, get us a 2.5 24, and then LAD will be 3.0
38.
38.
Yeah, you could have gone with a 30 balloon. Anyway, no, you had to.
Okay, wait. I think I have to go with 30 balloon. Or you
why
mean
you
for
got
the
the
LAD?
diagonal? Why in the diagonal?
No, I'm not in the diagonal. That was in the earlier.
Oh, okay.
I think this diagonal wire came back a little bit.
Samin,
Yes.
Anu, placing both wires was no problem at all.
Yes.
No.
Samin, very interesting presentation with several issues which I think still will need far more clarification, particularly
the
I think the FFR in the
32 maybe
ACS
not, no?
substrate. But it's in many ways it is not surprising. These are the thoughts we always had, that you cannot really treat a stable and a ACS lesion the same way.
Go up here.
Yeah. Absolutely, absolutely. That's the key. And there is a study called famous non-STEMI that also said the same thing, that actually,
No.
although we do many times, and there are some data, the preliminary trial did show that FFR guided for the non-culprit lesion, but STEMI, I think those very primitive. My recommendation would
Okay,
be
ready?
that we should not be, FFR is only for stable ischemic heart disease patient.
Go.
Right.
You have to go distal at
For
1
what?
o'clock.
I
You have
mean,
to
it's
open that
amazing how underfilled that LAD was. This is such a large.
Okay, 38.
Yeah.
You have 3038 and 22524. Go up here.
Yeah, let's open the, no, but do you want to
Down.
use angiosculpt, because it
No,
is
no.
not fully opened?
No, LED is open now.
Sinai? Or fluoro, whatever.
There.
Okay.
Open. 3038 and 225.
So the European
24, 28 you want.
Society's recommendation, of course, is impractical about leaving these patients on 5 days of therapy before you
28.
measure FFR.
Yeah.
No.
Yes.
28.
Somebody has ever written about or thought about, let's say, in the US or even elsewhere, these patients with ACS come, you put them on a dose of Cangrelor. Does that help you along to abbreviate the
SS 120.
5-day waiting?
Yeah, but remember that champion itself,
Right,
not champion PCI, did show some benefit, but I think the IV, particularly with the newer agents, to me, I don't think
What
the
is
IV Cangrelor will have a big role.
Right.
And that is what is going on at present, that overall the adaptability and use of the IV Cangrelor is very, very limited.
Well, I think that is more to do with the drug being given to another company.
Exactly. That one, and secondly, that we have now, all those studies were done against clopidogrel, which
Right.
takes 3 to 4
Nobody-
hours.
Yeah.
And now we have the newer agent, which takes 40-45 minutes. So that much is the usual delay in our procedure after the patient comes to the cath lab or initial stabilization. So therefore, I think things are a little different now compared to what these champion studies were done. Champion PCI, champion Phoenix and all.
Right.
Is that 28?
So there is a question for you, Samin. What is the percentage of your dedicated two-stent strategy?
Yeah, it's about the same, around 20%. So 1 in 5 will use a two-stent strategy. So it's about, I think that's basically the number, because the same thing, if you take every trial, or I would say for that matter any trial, so very rarely you'll have a single digit two-stent approach in the conventional or provisional stent strategy. In some cases you have 32%, but it will be around 15 to 22%. So around 20%. So clearly those are the lesions you identify beforehand, like this case, such a diffuse diagonal. You know that this is not going to remain open if that's your plan, and therefore it's very important that you go with the two-stent strategy as planned.
How often are you using FFR for the side branch?
Yeah, that's another good point.
Never.
So, yeah, I mean, very rarely as we have done here,
Right.
but the overall, because of since the DK Crush 6 trial showed that this FFR incorporation in decision making of the side branch does not help. So therefore, I think it is kind of gone for the favor. I think it's okay when you don't want to do PCI and you want to guarantee that there will not be any problem, and that time you just do FFR to document that there will be no problem.
On the basis of what you presented today, are you going to be going back and using the Coulette a little
Which one?
more?
LED?
Diagonal.
No, diagonal is okay.
Yeah. I'm sorry, you said something?
Would you be using, based on what you presented today, and with almost the published literature taking a mild step back with the Coulette, would you be using it more often?
Oh,
Yeah,
Coulott,
no,
you mean?
Yeah,
No,
yeah,
no.
we are not. Again, because we are very good, because you know what? The mini crush or DK crush.
Right.
Mini crush probably
Has
more.
worked well.
works very well.
Yeah.
And that we know that the DK crush,
Yeah, good.
The
Okay.
DK crush
Go
was
up.
very, very good. Here the,
LED.
so
You
I'm
go up
going
with
to the
dial.
diagonal now. So this is what we do. As we have shown many times, right here in our, tell them what the stent sizes
Yeah, this
are.
is now 225/28 in the diagonal, which we have inflated, and you see just maybe a millimeter of the stent is sticking in the main vessel. So we went up, dilated, done.
Yeah,
Go twice.
pull, now pull back a little bit. We have to go a little higher because that dent has not disappeared from the diagonal.
Which dent? Here.
Yeah, good. So now you pull back and now you can go 20 atmosphere and clearly that you have a little, so that, now it's good.
Down.
I mean, the entire key is going to be the final.
Kissing balloon.
Kissing balloon, yeah.
Clearly that every study
Right.
have shown that final kissing balloon
That's
is
the
very,
whole-
very important for decreasing the overall target lesion failure in these two-stent strategy.
So now the balloon as well as the wire of the diagonal will come out, and now you go up with the LED. Yeah, go up with the LED. Good, 12.
Make a trip better, otherwise you get a new one. Okay, take this balloon out.
You mean the fielder?
New
Fielder.
fielder.
No. Oh, you took out the fielder wire?
Yeah. That's a
Okay.
broken.
Down.
Chip.
Usually the wire that has come out of the side branch, you leave it in the guide and you can use the same wire to go back.
Right,
But
right.
the wire is,
Rather than taking it all the way
yes,
out.
yes. Down,
Yep.
go up again.
So the TCT viewers are going to watch some live cases from Mount Sinai.
That's it. Yeah, we actually have a atherectomy. Our session will be on Wednesday, November 2nd. Atherectomy, we'll show the demonstration of both rotational atherectomy as well as orbital.
Perfect site to be doing these from.
That's it.
I mean, nobody has more. I
Ready?
think that is very, very astute that people will get an appreciation of the two techniques.
Yes.
Looking good.
Good. Now, what balloons you want?
No, let's cross, and I think for the side branch we go with the 2O. We don't have 2O, right? We never opened the 2O balloon. Yeah, 2O12, new balloon. Give me a fielder. Yeah.
You're not
Cross.
trying.
And we have a 3O that we use for the LED.
Whatever you ask.
Not,
Yes.
not planning, Anu, to do any balloon dilatation of the diagonal. It's too diffuse, and why dissect it?
Which
Leave
one?
it alone.
No, it doesn't look dissected. It looks good.
No.
Distal.
I'm saying that would you want to put a balloon distally in the?
Oh, no.
That's what I'm saying.
Yeah.
Yeah.
No, but once you bring, I think you can do a distal edge of the stent. You can definitely.
Slightly, yeah.
Yeah, 2O. With a 2O balloon that we can do.
I'm not a believer of this, distal edge massage
Yeah,
and
yeah,
go
yeah.
here, go
Look,
there,
it's-
balloon here,
No,
balloon
then
there.
you dissect and then you are placing multiple
Nothing happens
stents.
to this vessel. You will see them when they come back. They are nice.
Get a 2O balloon compliant. Yes. What is that?
Is this patient on the good old clopidogrel?
Yeah.
Yeah. Actually, this patient is appropriate, will be a appropriate case of the twilight trial. That
No, we don't know
yeah.
that you don't want to stop aspirin
yeah,
at the end of
that's
3
using a
months.
more stronger antiplatelet, or somebody that diabetic, I would go with a little more aggressive antiplatelet therapy, whether be it may prasugrel or ticagrelor.
Right.
Yeah.
It's too diffuse, too many stents.
Too many stents, multiple disease. I think that's what we should do. If you are given loaded with a clopidogrel, we also know that you can give prasugrel 30 milligram, not a problem, and then give dose 5 or 10 milligram weight based, because we had learned that 10 sometimes is too much. So use a smaller dose, 5 milligram.
You have the 3O?
So are
For
you
the LED.
still for some dedicated cases, are you using any functional platelet assays, or it's all over?
No, I think it's all over. Basically, what is happening is, in those cases we are using, this is the, in those cases we are using this stronger antiplatelet therapy, and we know that those work. Dilate now. Yeah.
Not yet. Let's get the LED. Where's the 3O? High pressure 3O. Is this the one?
Yeah, because what has happened is that in those cases we are, although there is not enough data yet, till the twilight trial will be done in the stable patient, that using these stronger agent or more potent P2Y12 inhibitors, whether they'll have any role. So, but
Is
yes,
the Twilight trial Mount Sinai directed, the PIs and?
yes,
Okay.
yep. It's actually it's absolutely Dr. Roxana
Roxana.
Mehran is the global PI.
Fantastic.
I am the site PI, and that's being done now. Actually, we have included 12 centers in India,
Wonderful.
and then now they're opening up China and Germany and others.
Who's the sponsor of the trial?
It's AstraZeneca.
Excellent.
It's like $18 million trial.
Wonderful.
Total 8,000 patients. So now I'm 22. Tell them what balloons. 2O.
You have a 3O high pressure balloon. I
In the
can see
LAD?
You keep talking.
Yeah. The question is, do you want to go diagonal, little distal? Remember, there is
No.
a little edge.
Leave it. Now you know what? Go high pressure here. LAD proximal.
Let's go.
Yeah. I'm glad you slightly advanced it.
16, 18.
So how high are you with both the?
The side branch 12 atmosphere and LAD is 18. Down.
Okay. And both are non-compliant?
No,
Yeah, both are
diagonal.
non-compliant.
Diagonal is compliant.
Diagonal also
okay.
non-compliant.
2 non-compliant you give?
Yeah.
Okay.
I would have gone with a compliant balloon, always side branch.
Although the data are that you may go with the initially, but then you should be using non-compliant. So just to based on the literature, that yes, compliant have a better access. Many times the non-compliant will not cross, particularly if there is a too much
Right,
crush
right.
material. But ultimately, the ostium of the side branch you can only open by doing the nitro.
Anu, did you mention the compliant for the diagonal because it was 2 and you wanted it to grow a little
No,
bit?
no, side branch usually
As
when
it is,
you
you
have
like-
to recross the compliant balloon is the
Much
best
better
one.
crossable. Yeah. Okay.
Unless, I mean, if you go with the compliant and you see it is dilated well and you don't see any dent and you are happy, you are done.
Right.
If you see that the ostium has not opened well, then you go back with the non-compliant balloon and then do a kiss.
Excellent.
Nitro given.
You're going to give a little bit of verapamil here.
Right.
Yay.
That's okay. This will be good. You will get just double high dose. Yeah, that's fine. 1 second. Give 4 cc.
And you'll follow the patient, recommend good old fashioned stress thallium at.
No, bring back for next. No,
I
this case
think
now
we give
should,
one, you have to see him in the office, make sure he's still compliant.
I think this case should come back for the RPL and LPL lesions. Maybe OM2 you leave it, OM1, but definitely should get 2 more stents in that both LPL and RPL. That will be my recommendation because we have decided to go through the strategy of revascularization.
Everything looks good
Yeah.
there.
I'm still not very happy with that diagonal.
When he
I-
comes back, we'll show you the angiogram.
Yeah.
Yeah, I was more, I still in that particular view, I looked at the very apical LAD, but also it's
Bring
easy
that,
to agree with.
wire came in front. Take the wire out.
Yeah.
Start wearing dark
The
goggles
cable.
now.
Fluoro.
If we bring him back.
Yeah, he will
Right.
come back. Yeah, no, he's going to come back. So you'll look into it.
Samin, another quick follow-up question has come for you.
Yes.
That based on what you presented, the data of the FFR and ACS, should individual institutions start doing something or wait for any change in the guidelines?
Yeah, I would say that we definitely should wait for the guidelines. I'll tell you one of the big reason. If you see the editorial with this paper, they actually brought out lot of faults in this, and one of them was the same, that it's the same thing, that how accurately the FFR was done. Do you know where the wire was? And some of those cases did not have the full 140 or maybe 180 microgram adenosine dose. So there are a lot of issues. I think to me, this basically has raised the question, and that need to be prospectively followed.
So a work in progress,
Work
but
in
the
progress.
concept is exactly right.
Exactly.
Anu, excellent job with it. Amongst the numerous series of cases we've done, this turned out to be relatively easier, but it's also the kind of lesions people are confronting in their practice very often.
So if we
Samin,
can
any
come back
final?
to, we'll go
let's
to our
do your
questions
questions.
quickly.
Right.
That is the two points which we have. The recent trials of coronary bifurcation lesions and long-term prognosis of the deferred PCI by FFR. The recent trials of coronary bifurcation lesions showed that the two-stent strategy can safely be used in large side branch lesions, culotte and DK crush. Two-stent strategy seems to offer better long-term outcome compared to provisional strategy or TAP technique. And then data are emerging that while non-ischemic FFR of more than 0.8 predicts low MACE rates in stable ischemic heart disease patient, FFR of 0.8 is associated with higher MACE rate in ACS patient. A FFR cutoff of more than 0.84 may be more appropriate for deferral of PCI in ACS patient. This finding, and that's your question was, this finding of higher FFR cutoff in ACS patients need to be validated by the prospective trials, because what we have was just the observation. So quickly, the three questions. Following statement is true regarding the recent published data about optimal management of bifurcation lesions. That is, two-stent strategy can be used safely in all bifurcation lesions. The two-stent strategy is appropriate in 20 to 30% of bifurcation lesions. Culotte two-stent strategy is inferior to TAP technique. Large bifurcation lesions should always get two stents, and the two-stent strategy has significantly higher stent thrombosis in all the trials. And I have discussed all these points. Second, following is the true statement of FFR cutoff value in ACS. FFR cutoff of more than 0.81 is same predictive for ACS and stable ischemic heart disease. FFR cutoff of more than 0.9 is preferred in ACS patient. FFR cutoff of less than 0.75 is appropriate in ACS patient. FFR cutoff of more than 0.84 is appropriate in ACS patients to defer PCI, and FFR cutoff of more than 0.95 is appropriate in ACS patients. Of course, we have spoken that. The last question is, following are the factors likely associated with false negative FFR in ACS, except microvascular obstruction, plaque rupture, lesion thrombus, early FFR testing after presentation, or technical issues with the FFR calculation. And with that note, we finish our today's live webcast, which we were a little slow, a little late, but we all kind of finished in time.
Anu, any final words from you?
I think going just for the two-stent approach, what we have shown here, or what other approach that has been greatly discussed would be the DK crush technique should be the one that people should be focusing on if you are going to do two-stent approach for non-left main disease. For left main disease, of course, if there is which are large vessels, and you should consider I think the V-stenting or SKS, probably V-stenting more.
Wonderful. With that, we conclude this session. I hope this has been very useful. We'll see you next time on November 15.